Let's make CT great again. I'm here to go through what the medical physicist does on equipment evaluations, what's involved with that, and there's a lot of the talks are somewhat kind of overlapping it, so I'm going to just skirt over those and leave that to the other talks. Keith had talked about dosimetry and how we do that, so I just really won't spend much time on that, and then Tyler's going to be talking about the accreditation programs and the standards and such for that. So I got a lot to talk about, so we'll get moving. I would like to acknowledge some assistance from Doug Pfeiffer, my associates Michael Tressler and Chad Dillon for all the assistance they've given me through the years and learning CT and sharing our experiences out in the field. That really helps to make this process better. Also, what hopefully I'll get for you is to understand about the difference between the acceptance testing and initial equipment testing, annual physics testing, and equipment evaluations. Also learn that there are different standards for performing QC and performing equipment evaluations on CT. There are different sources for that. Also, the manufacturers have certain specifications which really differ a lot from what the professional organizations have in the accreditation program. So depends on what you're using as the standard when you're testing it, and you have to use the correct protocol in order to demonstrate that you're successful with that program. And then I'll just go through a lot of the testing to show you what comprehensive testing really involves. First of all, is when you first get a new CT scanner to your facility, the ideal situation is to perform acceptance testing on it. And that's a very comprehensive performance evaluation of the CT. And you evaluate many aspects of the scanner, and you compare it to the manufacturer's specifications. Okay, you told me if I give you this much money, this is what this is going to do, so you want to make sure it's doing that. So that's it's a very comprehensive and time-consuming operation. It's ideal to do that, but it's not always completely done. At that time, you also establish standards for and baselines for doing the QC. So we'll just set that up and work with the technologists. Also, there's all this protocols and reconstructed algorithms and software like that supposed to help minimize dose. So you would include evaluations to see is that really happening there. And that can be coordinated with the service engineer because they're there doing it and supposedly setting it up to meet those standards. So it's good if you can coordinate that effort together. Since acceptance testing can be quite time-consuming and quite complicated at times too, and everybody wants their scanner as soon as possible. There's also the initial CT equipment evaluation, which may be a downsized version of the ideal acceptance testing. So it's more comprehensive than what you might do on an annual survey, but it's not quite as involved as a complete comprehensive acceptance testing would include. You want to make sure it's compliant with regulatory requirements. So that's definitely one of the things you need to do before they start using it, hopefully. And then you want to confirm that it meets accreditation standards as well before they start using it. And then there's the annual medical physics survey, and that's just a performance evaluation. You're really going through a lot of the same performance evaluations of all of the different aspects of the CT scanner. And again, that's to make sure that it's meeting regulatory and accreditation standards. And then, of course, during the year, in between the time that you've done your annual surveys, things happen. They replace tubes and other parts of it that may affect the performance. And the ACR came up with kind of some guidance. So there is something on the ACR website under the frequently asked questions that gives some guidance on what you need to do after certain changes. These are not requirements, these things you should do, and you need to work this out. So it tells you whether the physicist needs to come on site and to perform follow-up corrective action, or this can be done as medical physics oversight by working with the technologist that's on site there. So if we're going to be making sure things are compliant with standards and regulatory requirements, what are these standards? Well, the AAPM and the American College of Radiology, they all produce standards, and actually a lot of us were really duplicating efforts in different organizations. So there's a lot of cooperation now, and a lot of the standards now are joint standards, and we also bring in specialty professional organizations to kind of help make sure we're covering all the bases. So you can get the copies of those standards from those professional organizations. And then the accreditation bodies actually provide standards for what they have. So the ACR has, they have their accreditation standards, which are different than the professional standards. So there are different resources. They basically are the same, but there may be some differences in there. So you need to get the specific copies, whether it's the what applies during accreditation or overall what a quality program should be. The IAC has standards, RadSite and the Joint Commission all have standards for medical imaging and the advanced imaging modalities. So you can get copies of those from all their websites. As far as regulatory requirements, that's what you guys do. Many states have implemented CT-specific regulations that have gone beyond the basic X-ray. California, of course, really was moved by the major incidences regarding patient dose, and so therefore that kind of moved a lot of it. So there are requirements for recording patient dosimetry, and requirements for scanners, and they're requiring accreditation and such. South Carolina has, that's where I'm in that area geographically, so I'm familiar with that, and know that they have certain things that we're supposed to do when we're doing CT that's not applicable to regular X-ray equipment. And then North Carolina is in progress of developing those as well, and I'm involved in their working group to kind of give them some guidance, and we're getting close. And so it's really good that they're finally kind of addressing, and more states are getting involved with that. And of course, the organization here, the CRCPD, has the suggested state regulations in Part F, Section F11, that gives guidance for states to adopt these regulations that can be used for those who want to regulate the use of CT in their states. So as far as accreditation requirements, Tyler is really going to go more into the stuff, but I just wanted to touch base with it. There are right now 4 that are approved by CMS. It's more of a reimbursement type thing that's driving it. But as far as in their standards, none of them require a specific phantom be used for QC, for the evaluation. The ACR does require that you use the ACR CT Phantom to submit images for the accreditation process, but that's just done when you accredit, and then when you re-accredit every 3 years, you need to do that. IAC and RadSite require that some type of image be submitted, but you can use the Phantom that's applicable to the scanner. The thing to note about IAC is a lot of what drove that is because the ACR doesn't do cone beam CT, the dental units and things like that, they really accredit a lot of those type scanners, and they therefore the Phantoms are all different for those as opposed to CT Phantom. So yeah, it's really difficult to even use the ACR Phantom on a cone beam CT and get any useful information. But here's some of the different Phantoms that are available for doing equipment testing. You can use the manufacturer's Phantoms. Siemens has, all of them have their own, and a lot of them have automated programs that you can run that'll give you some of these parameters that you're looking. The thing is that when their manufacturers designed specifically for that unit, and so they can program it and therefore get that. But it may not allow certain physics measurements that we want to do. So if you use that, then sometimes you have to do just additional evaluations using the ACR Phantom or some other type Phantom. Of course, the ACR CT Phantom is widely used because a lot of people that use clinical CT are accredited by the ACR. Since they're going to be submitting them every 3 years, let's just continue to monitor that through the year. Just say, okay, you're still within these specs for the ACR and such. And so we can just keep comparing that and make sure we're involved to that point. Of course, there's the Phantom Lab, Catphan Phantom, which is the gold standard. That's what I did use before the ACR Phantom came out. It really has a lot of advanced evaluation utilities, but now I rarely bring it out. I have it, and it's more of a relic than anything, but because I just use the ACR. I was actually on the initial CT accreditation committee and really thought, it's like, we don't need to make another Phantom. We don't need to make a Phantom. And then when I got on that committee, I was like, yeah, we do. It's a lot cheaper, and it does what we need to do. So it really is a good Phantom. So that's just an example of what the ACR Phantom, it's Gammex 464 Phantom and what it can do. This is just an example. It's got 4, is that showing up? Yeah, it is, okay. It's got 4 modules here that you can see. We've got a homogeneous module for doing uniformity. It's got an area for doing CT numbers and slice thickness. It's got high resolution and a low contrast module in there for performing the different tests. And here we have the Catphan 500. It kind of it's similar. Has a homogeneous area, high contrast area, low contrast area, and it has the ramps and for doing CT numbers. And then there's this one here is from the AAPM. They had designed a Phantom a while back, and a lot of people use that, and it can be used for doing a lot of these tests. So that's what some of the Phantoms that are available to us. The IAC has its standards, and then you can just go to the website and download them. And it really, the thing to note is just says that you need to measure dose in some aspect. The qualified medical physicist needs to do this and evaluate clinical protocol factors. And these factors must be listed on the report so that you're identifying. As Keith was saying, you need to identify what are we doing? Is it CTDI 16, CTDI 32? So we know that we're actually measuring and use it as a reference and use the appropriate phantoms and instrumentation, and they should be calibrated. So these are required. So you measure these and get the dose indices and record them. Now, they're really loose on what they want because, like I said, or IAC, there's the cone beam CT is involved in there. So they just say that you need to use a national standard, which is either CTDI, MSAD, or DLP to record it. And it needs to be pitch corrected and such. So this is an example of all the annual tests that the IAC requires. And it needs to be appropriate to the CT scanner that's actually being accredited. And so they really took a lot right out of the ACR program. And the image quality part of it that they want needs to do the image noise and the CT numbers and artifact assessment, spatial resolution, and low contrast. And then RadSite has similar requirements, and they have a list of there, and they pretty much list the same requirements. But then I'm sure these will be addressed a little bit later. The big thing is they have action limits, and they have action limits based on the phantoms that you're using. And so you could actually reference those depending on what program you're using and what phantom you're using. There are minor action limits, which means, yeah, I see something that should be addressed, or here's a major or severe one that needs immediate corrective action, that type of thing. So it wants to make sure that you document all of that. And then another thing that stands out with a high contrast spatial resolution, it does have a requirement to see greater than 6 line pairs per centimeter or equivalent. The one probably most people are really probably used to is the ACR manual. What's really good, it's just a recipe for doing QC. All of the steps are outlined in there. I think people have probably gotten copies on it, and it's based on the accreditation program and using that phantom. And then the summary forms are provided in that as well. This became effective a year after it was published back in December 2011, so it became effective 2012. And so most physics documentation can be done using the physicist form. Like, physicists like to do their own thing. You know, they have their own spreadsheets. You know, if you have, you know, we have 10 physicists in our group, and we have probably 12 different ways to do things. That's, depending on what we have there. It's really kind of interesting at times. Also, the thing that they have is they have control limits. If you're going to have what the action limits are, you also have the control limits. So you have to establish these to make sure that that things are operating within these control limits, and that when you go out of that, if you're using the manufacturers, use the manufacturers' baselines and control limits, and if you go outside of those, then you need to take corrective actions. As I said, with the alternative approaches, you know, even though we use the ACR, if in the ACR accreditation program, you can use the manufacturer's Phantom. You don't have to use the ACR Phantom. But if you use it, you have to use their method. You can't like use their Phantom and then use a different method to do it. Unless you do it right the first time at acceptance testing with their Phantom, verify that it passes with the manufacturer's protocols, and then it passes their criteria. And then if you have another method of doing it just for quality control, because quality control is really just seeing that it maintains a performance level, then you can use that. But at initial acceptance, you need to verify that it meets the performance criteria established by the manufacturer. If there is automated type software evaluations involved, you need to verify manually that that automated software is valid at acceptance testing. So that needs to be done as well. So this is a list of what the ACR really wants you to do. It includes the review of clinical protocols, and so you want to go through and make sure that the protocols are appropriate for that scanner, for the patient population that you're working with, to include dose and image quality. Scout, prescription, alignment light accuracy, image thickness, table travel accuracy, radiation beam width, which is really actually measuring what is the size of the X-ray beam, not the size of the image that's reconstructed. Low contrast, performance, spatial resolution, that's high resolution that you're looking at, CT number accuracy, artifact evaluation. You know, that's part of the ongoing QC that the site will be doing, but it's amazing. So a lot of times during the annual, or especially on the initial, you'll see some artifacts that stick out that need to be corrected before they start using it. So then you can grade it whether it's major or minor that needs immediate correction before clinical use, or it needs to be either monitored or just you go run through a few calibrations, see if you can get rid of it. You need to do dosimetry and then evaluate the display, the acquisition workstation display. Does not include the review workstations, not for radiologists. That's out the side of the scope. It was deemed, and that's just should be done based on other standards and such. The protocol review, they recommend that you review at least 6 protocols, including the classics that we submit during accreditation, the adult head, the adult abdomen, the pediatric head, the pediatric abdomen, and then high-resolution chest is recommended. If you do brain perfusion studies, then you need to do an evaluation of the brain perfusion if you do those. So what you need to look at as we're evaluating the protocols, and we're doing this with a team of the radiologists and the technologists, is to make sure, is the KBP appropriate for that type of procedure, the mass, rotation time, you know, is it going to be too short, too long? Is the detector configuration correct for what we're doing? We want to make sure that, you know, depending on what the radiologist wants to see, are we doing this most efficiently in order to minimize dose and such? And then look at reconstructed image thickness to see if that's appropriate clinically. Of course, a lot of that's the technologists and radiologists that need to deem whether that's clinically relevant for those, and evaluate the reconstructed algorithms such as ACR or IRIS or things like that are being applied to help minimize dose, to see if they're being used effectively, do you have it set up properly, and then the dose reduction methods that are being used, are they being optimized? And so you need to look at that and work with that team. You need to be rules for to make sure that you maintain these protocols once you establish them. All right, and the ACR is actually given some guidance on the clinical end, recommending reconstructed scan widths for certain scanners, pitch for pediatric. Even though they have some recommendations, you just really need to evaluate. Sometimes you can go for a pitch less than 1, and the dose efficiency is less. So you just need to look real time and look at what the goal is really to get really good image quality while keeping the dose as low as we can. On multi-slice scanners, sometimes you get a lot of different opportunities on what kind of detector configuration we can do. And so sometimes it depends on what you want to reconstruct, what you want to see. So you want to minimize the dose. Sometimes if you're going to want to use smaller slices to reconstruct more type images, if you're doing volume reconstructions, you can get the same detector radiation beam size, but using different detector combinations. For example, a 5x4 slices can be 30% more dose than 5x2 millimeter slices. So you can change these to optimize what that is. Another example is that for a 40 millimeter beam width, we can just do 40 by 0.6, and it's giving us the same radiation beam width as a 20 by 1.2, but you can get more reconstructions out of that. So those are the kind of things we want to look at. And then if you want to use lower KB settings for pediatrics and such, you need to evaluate that. Are we using it for contrast? Can we optimize the contrast that we're using? Another example is with the high resolution chest. One of the things you want to look at is that it's a high resolution chest, so we should have an appropriate protocol to make sure that that's giving us more resolution. All right, so GE recommends a bone algorithm, some have detail, but then there's some places that they would just use a lung, and it doesn't give you the additional high resolution that you want. So what we want to do is get that high resolution, because we get one image and then move 10 or 20 millimeters, and we just want to make sure we get the high resolution on that image that we're looking for. So you need to work with the radiologists and the technologists on that. So, and then when you're evaluating these protocols, the doses should be as low as appropriate. And then the ACR has the pass-fail criteria as well as the reference levels. The pass-fail criteria means you really don't need to exceed this at all. There's no reason. But you got to remember, if it's a CT of the abdomen, that these reference levels and such are the levels for a routine CT of the abdomen. It's not the same as a CT angiography exam. So those things are going to need to be set up differently. So the whole goal is to design to optimize the dose and image quality together. All right, so that's part of the thing you do initially, and then on an ongoing way, you're part of the team that is optimizing protocols. And then during the annual survey, you do reviews of this on your own, and then if you have more input, you need to discuss this with your team. So as far as some of the tests you need to do, there's the scout prescription accuracy. You're doing scouts. Scouts are important because it's used for positioning, localization. It's used in auto MA, so you want to make sure this is working properly and accurately. So what you want is a phantom that has these fiducial markers on it so that you can see them on the image and make measurements to verify that the prescription accuracy is within tolerance. So you scan the whole phantom, in the scout mode. You magnify the image so you can get a better look at it and get your cursor positioned properly so you can make the measurements. And then you perform an axial scan using a reconstructed scan width of 2 millimeters or as thin as the scanner will do. A lot of the older scanners, you're minimized on how small you can be, and then some of the others you can get smaller. And so here's an example of, here we have our axial part here to show that we're in the right position, and then we can measure across that and verify if I put that in and slice 0, that's when I do an axial scan there, that's exactly the location that my phantom is on the image that we get. You can also do this with the Catphan. It also has fiducial markers on here. Align the phantom dots with the lasers. Take the scanogram, and again, here's the scanogram, and you can do the measurements the same way. And that's just showing that you've nailed it. You got the fiducial markers, and therefore you can make your measurements to make sure that your prescription is accurate. The alignment light accuracy is just looking at the lasers to make sure if you put your lasers on there, is it going to scan at that position where it says it is? Because you position the patient there, have the lasers, and then the technologist will zero the location of the table, so it then normalizes and calibrates the table for that patient so that everything's moved relative to where you zeroed it out. This is really important when biopsies are being performed because you want to make sure you're at the right spot where you're going to be taking the biopsy from. So what you do, again, you need the phantom with the fiducial markers. And then use the alignment lights, carefully position it so that it's actually aligned up, that it's not angled or twisted and things like that. Zero the table and then scan the phantom. Okay, and here's just an example of taking an example of where the phantom is located at the 0, and you might want to take what we do is take an image before and after it, and it kind of just shows that we're centered here. I don't know if you can see that, but where you have that long the long rod here, that's showing it centered. You can see the fiducial markers are all in the image, and that's telling us that we're straight and lined, and so then we are lined up, and the accuracy of the alignment light is accurate. Okay. The Catphan, you can also do these same things. The Catphan has these, you hang it off on the box it comes in over the edge of the table. That's what it hangs on these rods back here, and then you have these positioning screws that help you to move it, to adjust the pitch and the yaw, depending on what you need to accomplish to align it. It's the same method that you do with the ACR Phantom. It has the fiducial markers here, and so you can see it straight, and then you can tell that you're positioned. You can also bring up the grid just to make sure you're centered. You use the measurement tools within there, and you verify that your phantom is aligned. Image thickness is one of the tests that is required to be done, and that is just when you are reconstructing from your scan, that's the slice thicknesses that you are getting, and that's defined by the protocol, and so we want to see if that is accurate. So it's really a problem. And so there are even thoughts of not having to do that anymore. But it's very rare that we see any issues with reconstruction thickness. Where there is an issue that needs to be focused is the radiation beam width. That can often be an issue, and so that's more important to be evaluated. But as far as image thickness, if you're doing it, you need the phantom with internal targets that allow you to measure slice thickness on reconstruction. And so the module 1 of the ACR Phantom allows you to do that. So you align the phantom like we did, you make sure it's centered, you want to make sure that it's not being affected, your results aren't affected by misalignment of the Phantom. So once you do it, which sometimes can be really challenging when you're doing that, and that can sometimes take more time than anything, is trying to align the Phantom. But once you do that, you try not to move it. Hope they don't need the patient for emergency ER or something like that, so you don't have to move it, so you can get all your tests done. So you zero the table once you get into the module where the image thicknesses are, and then you can get a scan. That's usually like the abdomen technique, somewhere around 120 kV, 200 mass, and then you do different slice widths and get an evaluation of whether or not it's reconstructing these at the proper slice thicknesses. The thing about this is with the ACR Phantom, each one of these rods that are here is about a half of the measurement. You want to look at all of these and look at the brightest, and then you look at the full width half max, so to speak, which you want to count all of those rods that are in there that are showing up that are at least as half as bright as the brightest, and then count them all and then divide by 2, and that will give you the slice thickness. So that will help you to verify that. And as an example, you can put a region of interest over the rod, and then if you have doubt, because if you do it, a lot of times you can do it by eye, just subjectively, and count it that way. But if you're concerned, particularly if you acquire them using a helical acquisition, they get distorted and they're really difficult to look at. But if you want to really confirm that the full width half max of these test objects, that you can put region of interest on there and actually measure the CT number and filter out which ones you really don't need to count. And then you can count them. So you would count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. You know, and so you have like eight there. So the module 404 on the Catphan will help you do full width half maximum as well. It's a little different because I have a different geometry of these things. You get the full width at half maximum of these objects, and you multiply it by 0.42. So here's an example here. You window and level based on the full width and half max evaluations, and then measure the actual ramp, and then multiply it by 0.42 is due to the geometry correction of the ramps that are in there. So 6 times 0.42 would give us a reconstructed thickness of 2.52. And so this is just an example. Catphan also added a new Phantom with a new module that is used for therapy, and they now have beads in there, and you can actually, when you're actually acquiring helical scans, you can actually count the beads and get the slice thickness that way as well. More importantly now, we have the radiation beam width. That's actually the physical measurement of the X-ray beam that's actually being used to generate the image. And again, as Keith was talking about, that's what really the dose is. The dose to the patient is the X-ray beam. So this is really far more important parameter to be evaluating. So there's different test equipment that you can use. You can use a CR plate, some kind of self-developing film. We use gaff-chromic film to achieve this. It's good to have an attenuator underneath it to just help get a better distribution of the dose if you can. There are some electronic test tools out there that you can use to do that, but we found that the method of using the gaff-chromic film is most efficient. So you just place the attenuator on the table. You center the table at the isocenter, make sure that the placement of your whatever you're using is at the center. And then you scan using all of the unique N times T combinations that there are. You don't have to do every combination, you know, on these 320 scanners, that would be a lot of time to do that. And you're going to have a lot of repetition there. So there really are these unique combinations that'll give you the same results. And so here's just an example of the setup. You know, we have this set up, and here's the gaff-chromic film sitting on there, and it's in the isocenter of the table. You use the lasers to make sure that you're properly situated. So here's an example of a GE Lightspeed 4-slice. We've gotten the scans here, and so here's the GAF chromic film. It's really good. You put it on there, you expose it, it just darkens right away. So we get that right there. So the criteria is to be plus or minus 3 millimeters, 30% of N times T. All right. So we look at that, and we get, these are the different slice thicknesses for that they should be, the nominal slice thicknesses that range from 1.25 up to 20. All right. And then this is just an example. If you plot this, you can actually plot this if you want to make sure your readings are accurate. If you want to get that way, I just use a ruler and measure these. But if you didn't get the right definition of that, then you might want to plot it to get a full width at half maximum for that. So what you can see here is that these are the different measurements that we got. And you can see that we have a problem down here, and that's relatively common on this scanner, that these are off at this, and unfortunately there's sometimes not much they can really do about it. They do try to recalibrate them and try to get them in, but we really find that on this scanner it's off. But you just need to realize that if they're using this, that's going to affect the dose to the patient. And so that can be something that can be applied during dose calculations. The thing is that this is the way that we do it. It's an easy way to do it. But if you go to the manufacturer, they have their way to do it, and they have different specs. So you want to make sure that you know that you do it this way. But you have to, if you're going to tell them they need to fix it, you can recommend that they meet the ACR requirements or the accreditation body requirements. But they have their own specifications, which are really a lot more liberal than you would think they are. In fact, they're plus or minus 50% of what it is. So if you have a 40 millimeter beam, it can be 60 millimeters, and it still passes. You can bring it to their attention, but they're probably not going to do much about that. We just stay on top of it. Sometimes you can get really good engineers that will work with you and try to get it better, but most of them say, I don't really have time, and I'm not really able to do that. The Toshiba, they're thin beams, 4x, and they may be 2 times wider than the nominal. And as you saw, the GE has its issues. Okay, table travel accuracy. We want to make sure if we're moving the patient, that when we go to a place, it tells us that we're at a different location, that we are being accurate there. And so we can just measure the difference when we move the Phantom from module 1 to module 4. Okay, there are fiducial markers, and that can show us. Sometimes you can add some kind of weight to the table just to mimic a patient, to make sure that if there's weight on the table, that might affect it differently than if there's just nothing on the table but your Phantom. So we usually have this really huge CTDI case that's there, and just put it on there. That adds a lot of weight to the table, so that kind of helps to add that to it. So use the alignment light and just position it, zero the table, move it to the next position from 0 to 120, and just see, does it move to 120? Translate that table extension. One thing you got to be careful of, depending on where you are, you might hit a limit on the table, and so you just got to be careful on where you're positioned when you're doing this. And then you record that table position, and it's really a pretty simple test. You just see if it's there, move it, and then if it goes 120 millimeters and it's on the high-resolution module of the Phantom, then it's accurate. All right. This is just showing that with the Catphan, they have the fiducial markers and they have distances, and you can just do the same thing as you can do with the ACR Phantom. Now, CT is what is it's really used for is for low contrast detectability. So that's a really important aspect that needs to be looked at. And so low contrast detection needs to be evaluated. And so they have to have low contrast targets in the Phantom, and Module 2 of the ACR Phantom has that. So you need to align the Phantom and then just and acquire the image using a clinical technique. Usually the adult abdomen is what we use, but for the accreditation process, you need to evaluate all of the different protocols, all 4 of them at least, to see, because you want to make sure can they meet the criteria for low contrast detectability, and CNR is the parameter that's used to do that. You need to disable auto MA because the Phantom is not a patient, and you'll get really low results and you will probably fail. You need to disable any of these iterative reconstructions that are on there because that could result in a non-defined type of situation. So you look at it and you acquire the image, get the series. You want to pick the image that's in the center because you want to minimize artifacts, but what you really want to do is find one that looks the best, what has the best looking resolution. Adjust the window and level to usually 100 and 100 window level works best, and then record the size and contrast of the smallest visualized target. So you look at that. Then there's a numeric CNR that's determined by placing a ROI on the largest object of that contrast, recording the target, then obtaining an ROI outside in the background and getting the CT number for that, as well as the background noise or standard deviation. And CNR will be the difference between those two divided by the standard deviation. It is noise limited, and you want to use the best slice. It's really sensitive to the reconstructing algorithm. If you start using a bone or a high detailed type recon, you're not going to get much of a CNR there. Here's an example of this module, and you're taking the region of interest over the test object and in the background, and you get the difference of the CT numbers, compare it to the standard deviation, and you get a CNR. And this is the difference of using the clinically used technique and reconstructed algorithm. And here is a bone algorithm, which gives us a very low and failing CNR value. So that can help you to help develop some of the protocols and give them feedback on protocols. But it really depends, what are they really looking for? If they're just looking for high detail, they don't want the contrast detail that algorithm would do, and the high contrast will give you high resolution that they want for the study that they're looking at. And the ACR has these criteria for CNR. The adult head has 1, the adult abdomen is 1, the pediatric head is 0.7, and the pediatric abdomen is 0.4. So we use those in that evaluation. Here, the Catphan has a lot more objects in it. It has large, and they go down to smaller type objects of varying contrast. They have 1%, 0.5, and 0.3% contrast that you look at, and so you can evaluate it at different contrast levels. So this is just an example of what it looks like on film. So you can see that you can count those. They start with 1 millimeter and go up to 9, so you can count the objects that you see, and then verify what you see. For at 0.5% contrast, we have, how many did we see? And then just keep a record of that to see if you pass and compare it to what you got at acceptance testing. You also can do numerical CNR values with this if you want, by placing ROIs on the test objects, put them next to it in the background, and if it's supposed to be 0.5%, then the difference in CT number between the object and the background should be 5, because the contrast scale is 1,000, and so if you divide the 5 by 1,000, that'll give you a 0.5% contrast. So you can verify the contrast that way. Now, we talked about high contrast resolution. There are line pair patterns that we use. A lot of people use MTF, and that's going a little more advanced into what you need to do with that. That usually can be done at acceptance testing, and some of the manufacturers do that automatically on their automated QC programs. But if you use the ACR Phantom or the Catphan Phantom, then you can just look at the patterns themselves. And you just align the Phantom. Again, you want to do all the same things. Disable the auto MA type techniques and the ACR type reconstruction algorithm, so you don't interfere with the evaluation. Always use the same type of technique on that and evaluate it at the various clinical protocols that are used at the facility. And this is just an example of here. It starts at 4 line pairs and goes up to 12 in here. So this is what you want to look at. And these are the criteria. 6 line pairs is what it should be to pass for your standard algorithms that are there. And high resolution, it should at least advanced A, because if you're applying a high resolution algorithm, then it really shouldn't result in higher resolution than what you're normally getting under standard conditions. And this is just an example of, you can actually use these test patterns and get data out of those with ROIs, and with the appropriate software you can plot MTF to actually calculate what your MTF is for that system. And you can do that with the ACR Phantom as well as the Cat Phantom. And this is the high resolution module for the Catphan, and it just shows it's got a lot more options to choose from, and that's just showing the side view of what it looks like. But here we are, we get 7 line pairs per centimeter here. So that's you just window and level to make sure you get what you get, and then make sure it passes your criteria that you established. Okay, CT number accuracy, and that is a test, and it's like, why is that important? Well, sometimes they use CT numbers in diagnosis to differentiate different tissues to make sure what they are, but they're really important in treatment planning. And so you definitely need to make sure that that's calibrated. Those calibrations are entered into the treatment plan so they can differentiate between whether it's soft tissue, bone, muscle, air, basically, that kind of stuff. So you just want to make sure that that's accurate. That's why we need to do this. So the Phantom has to incorporate various test objects so you can evaluate at least 3 different, 2 points make a line, but 3 make a more accurate line, So you want to make sure that you're looking at it that way. So look at water and air. Those are really important to help determine the contrast scale of your system. And for the CT Phantom, that's in Module 1. Align the Phantom, perform all of the clinical scans that you do for CT number accuracy, and disable all of those factors that I said. You get rid of the MA, auto MA, and all of the reconstructed algorithms that may interfere with that. And just use the average mass that would be for a patient. Because if patients are done using auto MA, the mass is going to be different depending on the size of the patient. And so you just look at what is the average patient size for this demographic, and just enter that, something similar to that, to do an evaluation. But one of the keys is, if you're doing it ongoing, you should use this same technique over and over again. But just be mindful of if there's any changes in their protocols. So you want to do the 4 that we include for most everything else. And again, here you want to select, because you're getting multiple images when you're scanning, you want to select one that's in the middle, that's not affected by the artifacts, because it is on the end of the Phantom, so you might get some artifacts from the fact that it's on the end. It's sitting on a stand that may give artifacts from the holder that it's on. So you want to make sure there's minimal interference from that. So adjust the window and level to optimize the visibility so you can get measurements on the Phantom. You can be mindful that these are energy dependent, and so most of these are calibrated at 120 kV, and so you want to make sure that you measure it at that. If you're going to measure it at other energies, you're going to have to establish new target values for those. Water, however, will be the same. And it should be the same. Water is water. It's the basis for the CT number scale. And so you want to make sure that is essentially 0. So you want to scan those at different KVs as well. Okay. Here's just an example of the CT Phantom and the different test objects that are here. And these are the criteria of what the different test objects should meet. So you want to take region of interest and place them in there and make sure they pass. If they don't, then what you need to do, just one thing I always do is recalibrate it, do it again if it didn't pass. Be mindful of what are the settings. Is there an algorithm problem that may be contributing to this? A lot of times you do CT of the head, they may use 140 kV. That's a change in energy. That's going to change your numbers, particularly with bone and Teflon on there. So, and here's an example. The Catphan also has a similar module in there, module 404, that you can achieve the same things. You also need to look at CT uniformity. So if we look at the CT number of water in a uniform part of a solid water phantom, then we want to make sure that it doesn't vary over the face of the phantom. So align the phantom, again, just like you would do with everything else, and do it for all of the different protocols that you're evaluating. Get region of interest, and you want to go in the center of the phantom, and then on the periphery, you want to go a diameter of 1 ROI inward, and take those and put them at the 3, 6, 9, and 12 positions, and then compare the CT numbers of water and make sure that the differences of any of these don't differ by more than 5. If it is, then you might want to recalibrate and see how that is. For accreditation, the limit is 7. You don't want to be more than 7. You won't fail accreditation unless it is over 7, but you will be given recommendations to recalibrate or adjust these issues. And then this, of course, is an example of the module 486 in the Catphan, where you can do the same thing, essentially. Okay, artifact evaluation. What you want to do is go through, use the uniform session, and to see if you get module 3 on the Phantom. And again, you want to align the Phantom, make sure it's all lined up. Use the mask that's appropriate for average patient size. You want to do one scan at the adult head with thin slices, because you want to see is the fact that we're using thin slices and different algorithms, is that going to induce certain artifacts? Repeat for different KV stations. And then once a month, you also want to use a larger Phantom if you can, to see some of those that are outside of the field of view that the small ACR Phantom or water Phantom has. And this is just the reason why we want to evaluate artifacts, because there is clinical implications that when we see these in the clinical, we want to see them before they appear in the clinical environment. So streak artifacts are usually caused by, it's amazing how much contrast gets down in underneath the table. And they go, I've cleaned this table, I've cleaned this table. And we just tear it up and go, no, you didn't. Look at this. A lot of times it's underneath on the gantry, outside the window there. And they get pretty nasty. Pull up the pad, you look under the pad, and that can get really nasty. And I see that because one of the first things I do is I lift up the pad to get my Phantom and stuff in there. And I'm like, I need some help here. Decon, we need the infection control committee over here. So you want to make sure, but if you don't do things like that, then you're going to see artifacts such as these streaks that are here. And then this is the classic ring due to detector imbalance or detector failing that's coming out. All right. And then this is an example of that monthly large Phantom, so you can get more of the scan field of view. If you can do it, yes, but the problem is these big Phantoms can be really heavy. You want to be careful on things like that. But it is something that a lot of people are doing. It is recommended. So this is just an example of some more artifacts that you can see that are due to things that are on the the scanner. People just need to take care of this. So it's really important that if you find phantoms, discuss it with the radiologist to see, what do you think? Do we need to do something before we, if you see ring artifacts, they definitely need to recalibrate or replace the detectors if they're clinically significant. With the dye and such, you just need to clean it up and then just verify that it's gone. Dosimetry is required to be done. Keith spent a lot of time on that. He's going to spend more time on it. It just needs to be done by the physicist. You need to, it's not just for patient dose estimate, it's just to make sure that the output is consistent. You can evaluate indirectly KV and mass and all that by doing this. The tube condition will affect what kind of results you get, and then you can have dose characterization. So you want to just do this for all the standard protocols. You measure those doses and verify it to what's displayed on there. And Keith had gone in through there and talked about the effects on displayed. And the important thing when the physicist is doing it, as Keith had indicated, you need to indicate how you measured it, using what phantom, and then you compare it to what the scanner came out with. The thing is what your scanning condition can really affect what's going to display. So you're going to change the field of view, and that can change the phantom that's used as a reference. So that's the thing that has to be careful. So when you're recording your data, you need to be sure that the physicist has recorded it to indicate which phantom is the reference for the dose that he determined for all those different protocols. This is just an example of one of our forms that we have, and then here's just more of a close-up. And here are the 4 scans. It has the criteria here of the reference levels for the ACR and the pass-fail. We have the measurement, and then we also have the display value, and shows the difference, the error that occurs between what we measured and what is displayed. Now also, the ACR also asks for CT scanner display calibration, and that's just the acquisition workstation. What you need to do is just evaluate the viewing conditions of that. A SMPTE pattern is typically used. It's on most of them, not all of the CT scanners. If not, you need to try, the physicist should try to get the pattern added. Sometimes we add them if we're allowed to, but they're really kind of picky about what you add to their machines. But most of them, what happens if there's a software upgrade or a data dump, the imaging patterns get dumped, but you can retrieve them from the service mode. And so a lot of service engineers have given us access to that, so we can bring them back out and evaluate using the SMPTE patterns. And then you have to have the calibrated photometer that has accurate precision and accuracy. It needs to be calibrated. That's one of the things. There are cheap photometers, and there are really good ones. You really should use a better one for evaluating viewing conditions, and it should measure at least 0.1 candela per square meter. So basically, you pull up the pattern and you do an evaluation. You want to make sure that all of these are, you see different changes. The density is changing all the way around. You want to see that. You look up here to make sure that there's resolution, there's straight lines, that you can see things. You don't want to see any curved lines or anything like that on here. You actually measure the 10%, 40%, 70, 90%, and then you plot it. Let's see if we can get that here. And this is the result of the plot. And then what you do is you plot what those are, and then you see if it's acceptable. And then what you do is you compare that from year to year. And then as well, you do a uniformity evaluation of it. And what you do is you place the photometer at 5 different locations around a uniform field, and look at the min and the max luminance that you get, and just determine a luminance with this formula of a difference between the min and the max divided by the sum of the min and the max times 200. For CRTs, the criteria is it should be less than 30% difference in uniformity. And then with LCD, it should be less than or equal to 15%. Okay. The ACR has a summary reporting form that you keep the data on. And so we want to keep the reports themselves, of course, are kept on whatever report the physicist does, but the ACR really wants that form of theirs, and this is an example of it. So you may see a lot of that sums up what it is. And so there may be some variations to this form that are done. And this is just an example of one of the automated softwares that's out there, and it gives you a display of all the data here. So here are all the different phantoms, and Iris has that software where you can acquire the data using your phantom and then use their software to actually evaluate the phantom independently. But if you're going to do that, you need to initially do it manually and make sure that it is valid, and then you can use this in ongoing. Additional things that can be do for radiation therapy CT simulators is use electron density. And as I said, that the CT numbers for treatment planning are essential for treatment planning. So there are all these different electron densities for different simulated materials, muscle and lung and dense bone, trabecular bone, and things like that, heart. And so you do evaluations of this, and then you can plot the CT number versus relative electron density, and then this is entered in the treatment plan. So this is showing the importance of CT numbers here. Another alignment tool that's available for CT simulators, because they use external lasers, and you want to make sure there's a registration between those. You want to make sure that's right. You can use this tool from TGM, the ISIS terrorist phantom that's here to be evaluated in radiation therapy. It's a good phantom for evaluating the lasers. It's a really good, quick tool that they use every morning. So I think I just made it. The big thing is to know that we base our annual surveys on the accreditation standards. We want to make sure we do all the testing that they do, meet their criteria, and then of course we really follow the standards of the ACR and the APM to make sure that things are done. And just be aware there is a difference between acceptance testing and annual testing. Hopefully that was somewhat helpful, and appreciate your time.